This is the MACP Inspiration and Insight series. If you were looking for the underwater basket weaving class, that's down the hall. So jump up and run down to that one. We have the wonderful Dr. Vicki Kress coming and speaking to us today. And you guys are in for such a treat. Several of you had the opportunity to hear her in an earlier webinar. And the unfortunate part is we had technical difficulties, which means we did not get the recording. So disappointing because so many people requested it. So she has been gracious enough to come back and visit with us some more and chat with us again. For those of you who don't know, I'm Dr. Sarah Stewart Spencer and I'm your Associate Dean. And so I'm going to be hosting. So we're gonna allow her to go through the topic, open it up, and then we'll take questions, either maybe 2/3 through and then maybe again at the end. So if you have questions, feel free to ask them, use the chat box or the question and answer feature at the bottom. Please know that we probably won't answer all of them and we'll get to them towards the end, but we'll get as much as we can in today. Our speaker today has a long history of being an amazing standout star in her field. She's been the Director of Advocacy for the National Board for Certified Counselors. She was the governor's appointed member of the Ohio Counselor, Social Worker, and Marriage and Family Therapist Board. If I literally listed out all of the professional contributions, we may be here for 15 minutes or more just listing those out when it comes to articles, books, presentations. Now the president of the Association for Humanistic Counseling. So you guys are in such a treat. I love it. So I'm going to hand it over to Dr. Kress and go ahead and get started. Welcome.
Great, thanks. Are you sharing the screen with me?
Nope, you have to share your screen with the PowerPoint, unless you'd like to send it to me, and I'm happy to do that too.
Oh, no, I can do it. Can you guys see my PowerPoint?
Nope. Go to the bottom part, press share screen, and then select your PowerPoint.
Okay, hold on one second. Oh, there we go, share screen, got it. Okay, there we go. Now can you all see it?
Yes, got it.
Okay, great. I'm sorry, are you, I think it may be set up a little bit wanky because my husband put 2 monitors on, which I hate. And so are you seeing like the main one or are you seeing the one with things on the side? I'm sorry about that if you are.
Seeing the main one and then seeing you. So we can see
good.
the main one and you. It looks perfect.
Good. Thank you everyone for being here today. I'm not the best with the tech stuff, so thanks for your patience with that. I'm learning. I am really excited to talk with you all about a topic that I care deeply about, which is working with and advocating for people who self-injure. I have been involved in working with this population for a really long time now, I guess about 25 years. I'm getting old. How I came to work with this population was I have a specialty in trauma, in working with trauma and abuse survivors. And as part of that, I had the opportunity to work for several years in a residential treatment facility with adolescents. And pretty much almost all of the kiddos with whom I worked self-injured. And at this point in the early 90s, I had never even heard about self-injury. I didn't know what that was. It was certainly something I never learned about in school. The only time I had ever heard of it was in the context of what they called, quote, self-mutilation, unquote. I'll talk more about why I don't like that term later, in the DSM. And they talked about borderline personality disorder and how self-mutilation was a possible symptom of borderline personality disorder. And so I think, kind of the culture at that time was, oh, well, if you are engaging in self-injury, then you must have borderline personality disorder, which is absolutely not true. And again, we'll talk more about that later. But anyway, I really didn't know much about this issue. It was very alien to me. I had never really even heard about it. It wasn't like nowadays where you see movies and TV shows and things where this is depicted. At this point, it was depicted literally nowhere. The only time I had ever even seen an instance of self-injury was in that movie Fatal Attraction, and that was a really terrible, dramatic depiction of self-injury and what that looks like. So anyway, so I started working with this population, and pretty quickly people started kind of looking to me to try to understand this and help them work with this population. And I really didn't know much of anything, and I was just trying to figure it out as I went, but it was really obvious to me that there was a lot of work that needed to be done in terms of educating people about this. And I decided that if I ever became an educator or a professor or researcher, that I was going to talk about this and try to learn more about it and study it, and maybe more importantly, advocate for this population. I've seen over the years so many examples of this population, I think, being abused, anywhere from neglected to, at one end of the continuum, to abused at the other end of the continuum. I had a job in the 90s where I worked at a hospital, at an emergency unit at the hospital, and I also worked at the psych unit. And I can't tell you how many people were coming into us who self-injured, and their therapists, their well-intentioned therapists, were saying to them, well, you're self-injuring, you are a suicide risk, you need to go to the hospital. So the counselors were having their own strong reactions to the behavior, and they didn't know how to understand it or what to do with it. And so their answer was, yeah, I'm gonna pass the buck on to someone else, and I'm gonna panic, and I'm gonna let other people figure out what to do with it. And you can imagine that's quite detrimental to the therapeutic relationship. And this population often feels, in my experience, misunderstood. And they've sometimes been the victims of, sadly, our own practices and our own profession, which really makes me sad. So before I jump in, I want to acknowledge that I sometimes how I think about self-injury may not be how everyone else, and even people I respect tremendously in the profession, think about self-injury. I come from a very humanistic stance, and that is a frame, if you will, for how I think about all clients' issues. And because I come from a humanistic stance, that colors how I think about things and a lot of my perception. So as I talk today, I'll share some alternative viewpoints on self-injury and some things that some practitioners and researchers and theorists who I respect tremendously do that I may not do. So I try to just like put my own biases out there so that you know what those are. So let's talk a bit about what self-injury is and what it isn't. Okay, so what self-injury is, if we break down the definition, is it involves deliberate, so it's conscious self-inflicted destruction of body tissue, which results in immediate damage without suicidal intent and for purposes not socially sanctioned. So in other words, what that means is people are deliberately doing this. They're deliberately trying to cause some type of damage to their tissue on their body. And they're not, by definition, engaging in suicidal behavior or having suicidal intentions. And the behavior isn't socially sanctioned. So for example, there's different subculture groups where people engage in different self-injurious behaviors. So for example, the BDSM community, for example, and so this is separate from that. This is tissue damage that is used as a coping mechanism or a way to try to feel better. So people will say to me things like, well, what about people who overeat? I know people who will just binge eat. Is that a type of self-injury? Well, not by this definition, because it's not. It certainly could be argued that can be a form of self-destruction, but harmful to a person. But that doesn't fit this definition as we're talking about it here. The most common types of self-injury include Cutting, that's the one you think the most about typically. But people also can self-injure by burning, self-burning. So I've had clients who will use different household chemicals, like maybe oven cleaners, to burn themselves. Maybe using cigarettes, matches to burn themselves, but I usually see chemicals. And something else that we often don't think about is self-hitting, self-scratching, interference with wound healing. So you'll see this a lot in different hospital or residential settings where people don't have access to cutting implements. They may fiddle and goof around with their wounds as a way to re-injure themselves when they don't have access to other means. The sites where people self-injure really vary. You see the arms a lot, but again, when you see the arms, that's because you can see the arms. I've worked with many people who self-injure, who strategically self-injure in places where they're certain that nobody is going to see it. So for example, your upper thighs, inner thigh areas, it's hard to see that, and that's also common. I've even seen people engage in self-injury or in their genital areas. The clients I've had who have done this are clients who have had typically extensive sexual abuse histories.
Dr. Kress?
Yeah.
Let's pause for 1 second. I just want to make sure, have you changed the PowerPoint slide? Because we're still seeing the title page.
Oh boy. Hold on here.
Just want to make sure we're not missing it.
Oh boy, the tech stuff, it gets me every time. I'm so super bummed that my husband did this. Yeah, I don't know how to. Hold on.
Do you want to shoot it over to me real quick, and I'd be happy to.
Oh, there we go.
Oh, there you go. You got it. Good.
Oh my goodness. Do you see? I'm so terrible at that. All I had to do was click on the other screen. I'm sorry. My husband set this up with 2 screens, and he knows I hate that. And so it's really confusing me, but it wasn't that difficult. So I figured it out. Sorry about it.
All right.
There we go. Here's the next one. Okay, we got it. Okay. So how common is this self-injury? How common is it? I actually do this work, and I'm often shocked by the prevalence of it. So I did some research with some researchers at Cornell, Harvard, Stanford, and we surveyed our whole campuses. And what we found was 17% of our students reported that they had engaged in self-injury at some point. Now, most of those people, over half of them, never did it again. But it's interesting that people reported having strategically engaged in some form of tissue damage and self-injury. That statistic even surprises me. Other research, when you go into the general population, so not college students, they've found about 1% to 4% of the general population has self-injured. And when you start to get into certain populations, the rate really skyrockets. So for example, in inpatient settings, 21% of adults. When you go into what I mentioned earlier, residential facilities or adolescent psychiatric hospital settings, you're talking 40 to 61% of these kiddos have engaged in this. And in my experience, it was more like almost 100% have engaged in this kind of behavior. Even in general populations of adolescents, we see statistics about 13%. And a population that many people don't realize that self-injures quite a bit is prison populations, whether it be female or male prison settings. They have astronomically high rates of self-injury in these settings, which is really, really interesting to me. You know, when you think about animal studies, right? And they look at rats or mice in captivity and how they respond, and they often engage in different types of self-injury. And so here, we take people, we put them in these really confined, isolated settings, and we see that they do the same thing, which is really, really, really interesting and something to think about in terms of a broader conversation about how we manage our criminal justice system. But that's not for today. Anyway, So what I'm going to do during this presentation is talk about some different activities. I know that you all as counselors in training really care about, what do I do and how do I help my clients? So I'm going to pepper in different activities that you can use. And you can use these activities with people who self-injure, or you can use them really with any population. People who have, say, depression or any kind of behavioral issue, anxiety, etc. So I want you to close your eyes. And I want you to, this is an activity to help kind of increase your awareness. So I want you to close your eyes and I want you to imagine a person who self-injures. What does that person look like? What does that person look like? If I was with you in an audience format, I would ask you what you see. And in my experience, usually people talk about females. They usually talk about younger people, maybe adolescents or a young female. People usually will say to me, they picture somebody who cuts themselves. They don't typically think about other types of self-injury. I want you to really be aware of the image that you conjure when you think about someone who self-injures. And I want you to do that along with other issues as well. So when you think about someone who, say, has ADHD, or you think about someone who has depression or someone who has substance abuse, I really want you all to be super aware of how you think about people who have these different issues, because we know from lots of research that we all have stereotypes about what these people look like and who they are. And it's really important that we're aware of what those stereotypes are, because if we're not aware of them, we can't challenge them. So along those same lines, I want to talk about gender and self-injury. Most people think young women who cut, self-injury. People might have a stereotype of like the gothic kid or the emo kid, right? That can be really dangerous to think about people who self-injure in that way. Now, indeed, in fact, there is a lot of research that suggests that traditionally females may self-injure more than males, but typically what we're researching is clinical help-seeking populations. So these are people who are reaching out and asking for help, and we know that males tend not to do that as much. So again, a lot of the research that's done on people who self-injure, they usually talk about cutting so they'll ask about cutting. And one of my huge pet peeves in the world is referring to people who self-injure as cutters. That literally makes I go into lecture mode. It totally makes my skin crawl. Please don't do that. And we'll talk more about why that's important later. But what we actually know is that men, when you look at like prison settings or hospital residential settings, we see that men self-injure quite a bit. But the ways, and I've done research on this, the ways men self-injure is often different. So males are more likely to engage in things like head banging. So maybe banging their head against the wall, punching things. So they're trying to self-regulate strong feelings and feel better by hurting themselves. And that is self-injury. Right? So when you broaden how you think about self-injury, you can see that there's a lot of space there to think about males as self-injuring as well. And how you would approach them is in a very similar way as how you would approach the more stereotypical person who self-injures. Okay, let's talk about some of the risk factors associated with self-injury. And before we talk about this, I just want to say that there is no type of person who self-injures. There is no like, oh, here's a risk factor for this, right? So there's some issues that we can look at and feel, pretty confident there are risk factors. So you take, for example, anorexia, people who have anorexia. There's certain personality traits that population has. There's a lot of perfectionism, anxiety. Sometimes there's obsessive compulsive personality tendencies. So feeling anxious and wanting to control things. We can safely say that that's a personality type, right? But when it comes to self-injury, it's really all over the map. There really is no type of person who does this, but there are some risk factors. And really these risk factors, if you think about it, are risk factors for any any mental health issues our clients might struggle with, right? So a history of child sexual abuse, a history of physical abuse, neglect, exposure to family violence, sexual assaults, rapes. One that stands out a lot in a number of studies is childhood illness. So people who have a prolonged childhood illness may develop a complicated relationship with their body, and that may cause them then to physically manifest their frustrations and struggles, which is kind of interesting. I guess that kind of makes some intuitive sense, right? If you're having a complicated relationship with your body, you may act out on your body. As is true with all issues, early attachments are really important. We know healthy attachments are the foundation for all good mental health. And so any kind of early separation, loss from parents, insecure attachments with caregivers, and just being, maybe having a biological predisposition to emotional sensitivity can be a risk factor as well. I want to talk a bit now about the functions of self-injury. What that means is, like, that's a fancy way of saying, like, the reasons, like, why do people do this? What are their reasons? What's motivating this behavior? But before we do that, I want to say that self-injury really, again, just like there is no type of person who self-injures, there is also no one reason that people self-injure. How I elect to think about self-injury is I think about it as a form of emotion regulation. So people are trying to make themselves feel better. I think it's really overly simplistic to say, well, this is why people do this, or here's this one reason people do this, because I think that there's many different reasons that people self-injure. And often, this is really important, guys, often over time, the reasons people self-injure evolve and they change. So the reasons a person may have started self-injuring may evolve over time. So let's take a look at what some of these reasons are. It's really counterintuitive, isn't it? Like, I want to feel better, so I'm going to cut myself or burn myself or hurt myself. It's confusing to wrap your head around. And I'm hoping this conversation helps you think about that and understand it a little bit better. So like I said, in a nutshell, it's a form of emotion regulation. I do trauma work, and so many of the people with whom I work have trauma and abuse histories. And for them, it may be a coping skill that they use to feel real. So depersonalization, they may not feel like they're in their body or part of their body, and self-injuring may pull them into the present and help them feel more themselves, more real. Related to that is like derealization, so a sense of things around them not being real. These are common dissociative symptoms associated with trauma. So when they self-injure, they feel real. They feel like things are around them. So it really orients them to reality and what's going on around them. It can help people escape a sense of numbness. People will talk about, well, at least I feel something when I self-injure. And again, you see this a lot with trauma, people experiencing a sense of numbness and not being present. Here's a couple quotes from clients I've worked with who self-injure. The pain inside was so much and I didn't want to talk about it. So it was just easier to cut and feel some sort of physical manifestation of the emotional pain. And this person said, some people cry, I cut myself. So I don't know what to do with these strong feelings I'm having, but I'm going to self-injure to try to cope with that. For some people, it eases tension. And for everybody I work with who self-injures, they talk about the cycle that they have around their self-injury of like kind of a build up, thinking about it, and then wanting to do it, feeling like a lot of tension around doing it. And then after they do it, feeling a sense of tension release, so any behavior that we start to become almost like addicted to, right? Like any kind of compulsive behavior. There's that sense of having attention build up and release that's often associated with self-injury. I find and this is clinically very important, I find the clients I work with who self-injure often have a difficult time using their words, identifying their emotions, expressing those, particularly anger. And so self-injury can be a way to relieve or express or communicate the anger that they don't know what else to do with. Okay, here's a quote. "Seeing my own blood was a rush for me. That sounds so gross, but seeing blood trickle down my leg felt really good to me. It felt empowering. It felt dangerous. And that gave me a rush and a feeling almost like playing God." Basically, you know, I would let it bleed and I would watch it and I would be like, wow, this is intense. Some people self-injure because it becomes a part of their identity and how they see themselves. And I think this is very, very dangerous. This is one of the reasons I would never refer to someone as a, you know, quote, cutter, unquote. My local newspaper here in Cleveland did a series about 15 years ago when some people were talking about self-injury, just starting to talk about it. And they did a series on people who self-injure, and they really put a spotlight on a young woman at a local high school who self-injured, and they really showcased her in this article. And it really upset me. And I remember thinking to myself, you know, she struggles likely with self-esteem, with self-identity issues, feeling validated, feeling heard. And then the newspaper comes along and they make her feel special. They put her on a pedestal, call her a cutter, the whole 9 yards, right? And how dangerous is that for her development to be receiving positive, you know, attention for doing something that is destructive? And I see this a lot in different settings. People will say, oh, here's our cutter's coming back, or she's the cutter, or, you know, people who self-injure, that's just a part of their experience. And it's a fleeting part of their experience. So please, I think our language is really important. And I just caution everyone to be careful with that. I think when it gets to that point that it starts to become your identity, it's much harder to shift that story. Self-injury is also, in my opinion, it's a type of suicide prevention. I know that's a different way to think about it, but when you're self-injuring, you're not engaging in suicide attempts. You're not life-taking, you're life-giving, if you think about it. So in that sense, it can serve an important function. Okay, here's another point I want to mention that's super important. Self-injury can also serve a function of influencing people around us. And what you hear a lot, again, in residential treatment facilities where the child care staff is often not very educated about trauma and self-injury, is they will talk about clients as being, quote, attention-seeking, unquote. Again, that's one of those things that really makes my skin crawl. It's aberrant. It's an aberrant environment to throw children in residential facilities and then to keep them there sometimes for years. I've worked with kids who were put in residential treatment settings as young as 5, and many of them had spent the vast majority of their childhood living in these horrible, horrible environments that are aberrant, and they're not adaptive to healthy human growth and development. So of course, when you're living in an environment like that, where you have no love and caring and support, you find ways sometimes to get those needs met. So you'll never hear me use words like attention seeking. And again, I would encourage all of us to advocate to not use that kind of language, but to think about self-injuring in these settings sometimes as a way people use to get their needs met. There's fundamentally different ways of thinking about it. Okay, I also think that another idea that I want to just share with you, I don't agree with thinking about self-injury in this way, but I think it's important that you're familiar with it. Vander Kolk, he does really, I respect him so much. He's brilliant. He does a lot of really great trauma work, influenced me tremendously. But he talks about self-injury as punishing oneself for feeling bad. So he talks about trauma reenactment, so that clients are trying to replay out the traumas they experienced on their own bodies. I choose not to think about it that way. I choose a different way to think about it. To me, that can be kind of a controversial way to think about it, because it's kind of putting, it's kind of negative and putting the blame for the behavior on the client in my eyes. So it's kind of a psychoanalytic way to think about it that I just don't really connect with. But I think it's an important theory to understand. People will say to me too, well, is this a learned behavior? Do people learn this? Is that why they're doing it? Here's where a client said this. I had a lot of friends that did it, a lot of girlfriends. And so I guess it seemed normal because a lot of my friends were very smart girls. So I thought it must be kind of normal for smart girls to cut themselves. This example, and in general, what I would say is that certainly the media and TV shows and movies and peer groups, I mean, these things can all influence self-injury. They're a piece of the puzzle, but I don't think that that's enough in and of itself, because like, as the research that I mentioned earlier I've done suggests, many people attempt to use this as a coping mechanism at some point, but the vast majority find that that really doesn't work for them. So to me, my thinking is that there's many other factors involved that cause a person to connect with this as something that they want to stick with, right? So for it to be sticky to someone, there has to be other risk factors at play there. Here's a couple images that clients who self-injure drew to depict their self-injury. So you can see here, she has her mouth closed, right? So it's kind of stapled shut. So she can't talk. She can't get out what she has to say. And you see she's crying. She has tears here. So she's in pain, sad, maybe sad, angry, feeling bad. And you see these injuries and cuts, and she's kind of holding them out, right? So to me, this is just a really nice depiction of what self-injury feels like, having things you want to say and communicate, but not really knowing how to communicate them, maybe to others, or how to even make sense of them yourself. And so you self-injure as a way to manage that. Okay, here's another slide. You see, she says here, I bleed, therefore I exist. So I feel real, I feel relevant when I'm bleeding. I want to talk for a few minutes about suicide and self-injury. This is really an important conversation. When I first started teaching and talking about self-injury, I put a ton of emphasis into how the two behaviors are different, and they are, as we've discussed, by definition, different behaviors. But that said, they do have a complicated relationship. So like I said earlier, self-injury is an attempt to cope or improve one's life, while a suicide is an attempt to take life, to destroy life. So they fundamentally have different motivations. Suicidal individuals feel helpless and hopeless, but people who self-injure are trying to get some control over their life and trying to cope. So they're different behaviors by definition, but there's been a lot of recent research that shows that when people self-injure, they're oftentimes thinking about dying. Look, you're not in a good headspace when you're self-injuring, right? And so thoughts of death, thoughts of maybe going deeper than you wanted to do go through your head. And then we also know people who recent research shows that people who self-injure do have a history of suicide attempts and do have a greater frequency of suicide attempts. So how I suggest you respond to this is, when you work with people who self-injure, you want to make sure that suicide is always part of that conversation. So certainly self-injury is a risk factor for suicide. And that's something I couldn't say 20 years ago that I can say now. We know that. So you have to take that seriously, and you have to assess for suicide at a first session, and then you also have to assess for it thereafter. But you can't overreact. You can't assume like, okay, you're self-injuring, that's, you're a suicide risk. You're going to try to kill yourself, or you're trying to kill yourself. It's a very, very delicate balance, and it's important we get that right. Okay, so I mentioned earlier I was going to pepper in some different activities. So here is an activity you can use with any population, people who self-injure or anything. Have the client write for 5 minutes about the self-injury, and you could give them a prompt like, the last time you self-injured, what were you aware of, or what were you thinking, what was going through your head? What does the self-injury mean to you? What does it mean to you to give up the self-injury? Talk about your ambivalence about giving up the behavior. Where is that hard for you? What do you get from it? What are you afraid to lose, right? So I'll ask clients to do this and not put their pen down. You can also, like some variations of this is you can also have them do like a voiced text and use technology, or you can have them like type about it. But what's really cool is, clients come to us and they have these stories they tell, and by the time they've gotten to us, they've told themselves and usually other people a story about the problem and what they're struggling with. And when you engage in an activity, a creative activity like this, it kind of makes them go deeper with that story, and it forces them to let down their guard a bit so that they can be more authentic about that. So that's just one example of an activity I like around assessing self-injury and what it means to different clients. In the end, what I always say is you want to ask clients what the behavior means to them. What is that about for them? And in my experience, pretty universally, I find clients have a very difficult time articulating in a meaningful way what it means to them. So part of our role is to really help them take a deep dive around that and really slow down and break down what's going on for them. They often can't articulate it. It's kind of like when you work with people who have substance abuse issues. They can't generally articulate like, oh, I feel hurt, I feel lonely, I feel sad. They can't often identify the feelings that trigger their drinking. And so we have to help clients figure this out. So I want to talk a bit about, and this is going to be a very gross overview, but just some of the treatment considerations that you need to think about when working with this population. First of all, the most important thing is going to be the boundaries of the setting that you work in. How much time, right? How much time do you have with that client? So say you're working in a school setting, and you might be offering mental health support or school counseling or something in a school setting. You might only be able to, meet with a client, a student for a couple sessions, right? Or say you work at an EAP, an employee assistance program, again, just a few sessions. If you work in a community mental health center, you may have many more sessions with a client. So much of the approach you take and what you do is going to be dependent upon how much opportunity you have to work with them long term. Also, the client's dynamics come into play. So I have clients who self-injure that we don't focus on the self-injury. Like that's not a big focus. If that's not something they want to focus on, and they've got other issues. So like say, for example, trauma issues. Again, in my experience, I find that I might only spend a session or two talking about the self-injury and reviewing safety planning and things like that. And then I might, move into trauma work. In my experience, my clinical experience, I find that clients who can resolve their trauma issues, often the self-injury melts away. That's an important point, what I just said. So if you think about it, what I'm saying to you is I see self-injury as a symptom of larger issues, just like I see addiction, eating disorders. There's usually bigger picture issues going on, and these are just symptoms. And so here is where I differ. I told you I'd be transparent. Here is where I differ from how some other people think. A lot of the people who write books and talk about self-injury, people who are brilliant and who I respect very much, they really focus in on just addressing the behaviors. So like a behaviorist will focus in on changing the behaviors, or a cognitive behaviorist might focus on changing the thoughts and behaviors. But what I have learned through experience over the years, in my opinion, is that you need to look at what's causing this, because I often feel like it's a whack-a-mole situation. So I could work with someone to stop self-injuring, but they're still feeling bad, they're still hurting, they're still struggling in their core. And then what happens is then they start drinking, or then they have an eating disorder, right? Like so something else, like that whack-a-mole where you hit it and something else pops up. So to me, it's very important to try to do the best you can get to the roots of the problem and what's causing these things. Okay, so in terms of some general counseling considerations, I talked about always assessing for suicide, consistently doing that, making sure you understand the client's relationship to suicide and where they're at any given moment with that. Something else I touched on, but I want to highlight here, is the importance of our counselor countertransference with clients. I believe, like, remember earlier I mentioned the example of hospitals and counselors getting reactive to client self-injury and sending them to the hospital to be assessed. That, to me, that was very much about the counselor's discomfort with the behavior and them not understanding how to assess it or what to do with it. And so I think it's super important that we be aware of our own personal reactions. And I've written actually in several journal articles about this, about work, just managing ethics issues associated with counseling this population. And I always talk about this issue of counselor countertransference. I don't say to my clients, you have to stop this behavior. Yeah, and again, other people I respect do. I don't. I think it's ridiculous. It feels like, yeah, there's a lots of things I'd like my clients to not do because I know that they're hurting them. But at the same time, it's not as simple as me saying, you're naughty, you should stop doing this. It just doesn't work that way. And so to me, saying to clients, you need to stop this behavior is a waste of time, and it's really not productive. So I don't focus on that, and I certainly don't require that they stop self-injuring. What I do require is that they're safe about it. So I talk with them about safety issues. I talk with them about how do you manage your injuries, and how do you know when you should get medical treatment, and how, when should you get medical help. I talk to them about talking to their medical providers about the importance of not sharing cutting implements and the risks associated with doing that. We have to be very, very careful that we don't overstep our scope of practice. So as counselors, we are not medical professionals. We can't give nutritional advice. We can't, we can't assess a client's wounds and assess the severity of them. So people will say to me, well, should I ask to see their injuries? I've never done that. Never done it, never will, never done it. My thing is, I want you to work with your medical provider on that. And I think it also opens us up to some liability when we start asking to see their injuries. So I guess my question to people is like, well, why would you want to see their injuries? What are you going to do with that information? You're not a medical professional. And one of the things too is I think it's voyeuristic. So again, especially when you're working with people who have experienced trauma and abuse, to look at parts of their body that they may not even feel comfortable having you look at, it feels victimizing to me. So like you have a history of sexual abuse, and your counselor is asking to look at pieces of your body that are private. I mean, if you want, if a client shows me their injuries, that's fine. I don't care about that. But for me to ask to get into their personal physical space in that way, I think that it could feel really violating. So I just don't do that. and I think it's a slippery slope to do that. Okay, one of the most important overall counseling considerations is that we create a safe, structured, caring, consistent, respectful environment. And that's true of all counseling, right? If we can just be a stable, predictable, caring, safe space for our clients, that's most of being a good counselor, in my opinion. And this is particularly important with this population. Another issue to think about is counselor competency. And I think this is a real slippery slope, because people will say to me all the time, people reach out to me and they're like, well, I've got this client who self-injures and I just don't know if I can do it. I don't know if I know what I'm doing. I don't know if I'm competent. Competency is always an important consideration, but there are very, 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 very few people out there who would report themselves as feeling competent to work with this population. So you can imagine, if you're working in a rural area and there aren't a lot of other providers around, where are you even going to send that client to? I mean, just by being at this presentation, this hour-long presentation, you may know more than many other people out there do about how to help this population. So I guess I'm saying you may know more than you think you know, and just be aware, am I not wanting to work with this person because I'm uncomfortable with the behavior, or is it because I really think I can't help them? So I want you guys to think about that. Okay, so what are some just overarching counseling goals? One is, obviously, based on what I said, you can tell, is helping clients to identify and express their feelings. So helping them to increase their awareness of their feelings and identify what function is this behavior serving for them. Helping them to understand what are the things that trigger self-injury. And there's research, and in my experience, it's very often interpersonal conflicts. So problems with a partner, problems with kids at school, problems with coworkers. So feeling voiceless and unsure about how to communicate in difficult situations can be a big self-injury trigger. I also work with clients to help them identify the cues associated with self-injury. And so what this means is, how do you physically and mentally become aware that you're going to self-injure? So I'll do something like a behavior chain analysis. I think I wrote an article about this. I did. I'm pretty sure I did. I think I wrote an article about how to do a behavior chain analysis with clients who self-injure. And so what that is where you break down like every little piece of that cycle of self-injury for them, so they can start to intervene and engage in different behaviors at different places in that self-injury cycle. If you email me, I can send you that article. I also focus on helping clients learn how to use behavioral alternatives to the self-injury. So how to engage in behaviors that are inconsistent with self-injuring. I try to help them learn how to get their needs met in safe ways. And that's a word I use a lot with this population, or trauma survivors in general, is safety. So I'll talk about safety, how they can be safe, feel safe, how they can nurture themselves and be kind to themselves. I use a lot of that language to try to create a different conversation for them around their experience in this world. Okay. So what does the research say is an effective way to work with people who self-injure? I always say that the research is limited because it's much easier to quantify and test for certain theories. So for example, behavior therapy, cognitive behavior therapy, those are much more easily quantified and easier to test for. And in fact, that's what, if you look at the research, that's what they talk about is like dialectical behavior therapy. Because dialectical behavior therapy was developed to use with people who have borderline personality disorder, and it has a focus on changing behaviors and self-injurious behaviors. There's been a lot of research done on that. So that, there's some research to suggest that's helpful. But again, I want to emphasize that at the end of the day, no therapy, no treatment works with any client if they don't feel respected, understood, and heard by their counselor. So that's always going to be much more important than any fancy techniques or interventions that you use. So like if you don't know how to do DBT, that's okay. You can still do a lot with this population without knowing fancy techniques. Okay, let's talk about negative replacement behaviors. This is a fancy way of saying, what about instead of self-injuring, what about doing something else behavioral to your body that causes discomfort, right? So for example, maybe snapping a rubber band on your skin instead of cutting, or maybe marking yourself with a red marker instead of burning yourself, right? What about using like an ice burn instead of a chemical burn, right? I do know, again, I know practitioners who I really respect who do use negative replacement behaviors. I don't use this. This is not a technique that I pull on. My thinking is that, and again, other people I respect tremendously who are experts on this think this way as like I do too. The way I think about it is I'm trying to teach clients how to engage in self-soothing adaptive behaviors that they can use anywhere. So if a student is in a classroom setting and she has an interaction with another kiddo that's frustrating, like she has tools at her disposal that she can use that are not physical tools. But some people argue that negative replacement behaviors do have a place in helping people get and move away from tissue damage. So that's something that you guys can think about and figure out what works for your style.
Hey, Dr. Kress, can we pause for a second and answer a couple of the questions since we're kind of getting close?
Yeah, sure.
Okay. So if you look down at the bottom of the screen and it should say Q&A and it has a little chat box like next to it, that'll pull up some of them. And then I'm also going to go back and reference some of the ones in the chat. Can you tell me if you
I think I have to escape out of there maybe.
If you want to press the stop sharing for a second, that might do it too. And then we can always go back to sharing. Can you see it?
Q&A. Oh yeah, Q&A, great.
While you're pulling that up, I'm going to scroll back through and grab some out of the chat. The one thing that I think continues to come up is this idea of, tools and techniques specifically for doing this. And one of the things that I think maybe just in summary to stress, because I've seen so many questions about this, is that if you're viewing it as a symptom, then you're treating the core. So if we think about a tree that has a leaf on it, you're not taking the leaf off of self-injurious behavior and going, this one leaf, I'm going to work with this today. Instead, you're saying there's something happening in the roots. And if I look at the roots, it actually probably addresses more leaves on that tree than just taking that one leaf off and only looking at it. Instead, you're saying, I'm going to look at the person, what's going on, and then how that impacts all of these other pieces going on in that person's world.
I really love that. I love that so much, that analogy. And I think what happens is because self-injury is so personally frightening for us and it feels so scary and confusing, like we get really focused on that behavior. So it's kind of ironic. I talk about self-injury a lot and my message is really like, yeah, don't get super preoccupied with that behavior. But man, whenever I talk about it, people come out. I mean, because it's interesting to people, but it's not something I think that we need to get super focused on. This conversation gets really tricky with children. I was pulled in on an ethics case with my state licensure board in Ohio, where what happened was it was a really complicated case, and what was weird was I got pulled in at first by the client, or excuse me, the counselor and her attorney. And then later the licensure board they reached out to me not knowing they had already reached out to me. But the situation was, it was a teenage girl who, her counselor had been trained by me, had come to my training. And the counselor was working with the girl, and she was saying, you know, her message was kind of like, I'm not going to make you stop this. I'm not going to give you an ultimatum that you have to stop this. But they had a safety plan together. And obviously they were focusing in counseling on engaging in healthier alternative behaviors and things like that. And then the girl had a hospitalization. She had many over the years, even before this counselor got to her. And the psychologist in the hospital filed a complaint against the counselor to the board, saying she should have been focusing exclusively on making her stop self-injuring. And in the end, the attorney general and everyone sided with how, you know, kind of my way of thinking about it. How do you make someone stop self-injuring? But it opens up some really interesting ethics issues, especially with like kids. So, because the parents are like, here's my kid, make them stop doing this. So what I do with parents is I educate them that this is a symptom of other things. And we're going to talk about it, and I'm going to encourage that, but I can't make them stop doing that. And if I try to make them do it, what happens is you often get into power struggles.
Oh, yes, absolutely.
Which is really unhelpful. I wrote an article too, I can share with anyone who's interested, on using I don't know if you guys have learned about motivational interviewing or motivational enhancement, but what that is a counseling approach that you use to enhance people's motivation to want to change. And I use it with addictions. I use it with eating disorders. I find it to be very, very helpful, because what you're doing is working with clients to help them want to make changes.
Yeah.
And this is part of DBT. DBT does have a small emphasis on this as well, but you can't make people change. They have to want to change.
Yeah. Well, and it goes back to this idea that if you're working on what's fueling the injurious behavior in the first place, then talk about a difference in, you know, and I really echo this approach that you're talking about, for the simple fact that I've seen it over and over and over again. Had a client that cut so much that her, entire body was covered in scars, to the point where you could easily even just open her skin if you pulled too much on some of the scars, because it had been gone on for so long. And the interesting part is, this had been going on for so long. No one had addressed that she had been sexually traumatized for so many years of her childhood. So when that became the focus, and it was, let's work on this, her cutting went from multiple times a day to once a month.
Exactly. Bingo. Ding, 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 ding.
And it's amazing to me that we haven't figured out, when you don't have a headache, you don't need Tylenol. So when you don't have pain, you don't need coping for it. And that could be that self-injurious behavior.
Yeah,
so
and that's exactly my argument. And I've worked with clients like that who, and not just with self-injury, with addictions, eating disorders, any behavioral manifestation of pain, where they have been in counseling on and off for 10, 20 years, and no one's ever addressed underlying issues or trauma issues in particular. And they're just continuing to struggle. And so to me, if I'm busy getting into power struggles with my clients and just focusing on, you need to change this behavior, how is that solving the cause of the problem?
It's not. And it's very parental. You should do that very parental. So let's dive into the question and answer section. So if you'll open that up, because I think that little discussion kind of addresses a good majority of what I saw in the chat. One thing from the chat that we haven't hit is the question of, can you injure yourself, meaning like your energy level, maybe spiritual level, in a way, if you take the same concept that self-injurious kind of can extend into lots of different areas. Would you say that?
I like that. I've honestly never thought of that before. I'm trying to wrap my, so the question is, can you self-harm your energy, your soul?
Yes.
Like, and I would say, like, the way I think about self-injury is I absolutely think.
I absolutely agree.
I mean, you're right. You're sending a message to yourself.
Yes.
That I am not worthy. I don't deserve tenderness and love and kindness. And I want to hurt not just my tissue, but like the essence of who I am.
Yeah.
Right. And that's, I mean, that's kind of powerful when you juxtapose those two things against each other in that way. I like that.
Yeah.
I'm seeing a lot of questions here too about culture. I'm so glad you guys are asking that. That's like a really good question. A bunch of you did. There's still, I need to update. I need to kind of dig into the literature. I'm going to do that tonight. I need to dig into the literature on that a little bit more closely and see if there's any new research out. But we haven't really gotten to the level. People have only been researching this for really aggressively like the last 10 to 15 years. Whereas like things like eating disorders, we've got like 40 years of research on it, right? So,
Yes.
so we don't know a lot, but I will tell you in my experience, I would say self-injury has really been a behavior that cuts across cultures, across race, ethnicity, age. I've worked with 60-year-olds who self-injure, and again, that's not something that you really think about. I've worked with people from lots of different backgrounds. I was a college counselor for 6 years, and I worked with music conservatory students. So these are people often from more typically from upper middle class types of families that had a lot of resources to invest in all these music lessons. And they had a lot of resources and at their disposal, lots of diverse backgrounds, cultural backgrounds they were from. And I would see self-injury at unusually high rates in this music conservatory population, which is nothing like that kind of residential adolescent. Yeah. I was working with children who had been sex trafficked. So like these children were a much different socioeconomic status and background. They were from inner city Cleveland. They had grown up in poverty, but yet I was still seeing this behavior across. So my experience is it really cuts across.
Yeah. So I'm going to go through and kind of check off some of these as we've addressed the cultural component here. Can we now dive into, let's see, I'm kind of going through the list here. Correlation between self-injurious behavior with children and parenting style.
Well, I mentioned earlier that there's research that people who self-injure have grown up in families where they haven't often experienced secure attachments, right? Like they haven't felt that healthy sense of attachment. And so I would kind of take that to think any of the less than ideal parenting styles would impact their sense of attachment, right? So like a kind of authoritarian parenting styles or disengaged parenting styles. I mean, I think ideally, like as is true across the board, you would want a parenting style that's more authoritative, right? Where like parents are parents, they have clear boundaries, but they're also really kind and loving. Because if you think about it, what ideally happens in early development is that we learn how to regulate our emotions. And a lot of people argue we do that very, very early in life based on how the adults around us treat us and respond to us. Yeah. So if we're self-soothed, I don't know if any of you are familiar with Margaret Mahler's work on borderline personality disorder development. She's an object relations theorist, and she has influenced my thinking so much. I think she's absolutely brilliant. But she talks about like just the first 2 years of life and how parents and how they respond to infants and toddlers impacts how that little person comes to understand their own ability to self-regulate strong emotions. Mm-hmm. So what we know is if there's inconsistent parenting, certainly any kind of child abuse or neglect, these things will cause a person to not be able to regulate emotions well. And then that's going to lead to all of the behavioral things we've been talking about, self-injury, addiction, and all of those things.
Let's take a question about, and this kind of centers, I'm going to make it a little more open, but the idea of countertransference. And if you have your own history of injurious behavior or suicidal ideation, so anywhere on when we talk about that spectrum component, but your own countertransference, what would you suggest for these counselors kind of going into the field?
Yeah, no, that's a really great question. And that question could be applied across the board to any issues we deal with as counselors, right? I mean, we're human and we're working every day with other humans, right? And so, you know, we have experiences, they have experiences, and we're always going to be bumping up against those. So I mean, obviously awareness of that is going to be critically important, and just an awareness that, oh, hey, I've had this struggle, my clients got this struggle, like stuff could come up, right? Like, so to me, that awareness is the most important part. And then from there, I would encourage, you know, all of you, if you haven't already been in counseling, to get into counseling, because if you don't sort out issues, they will come back up. And another thing is, I think that's like an ongoing process. Like, so when I was in grad school, it was like, you're a counselor in training, you should get into counseling. And I thought, okay, I got that, I'll do that. But what no one ever said, and I wish someone had said, is like, hey, you're a human, and throughout your life, you're going to have many more new issues that come up. That, you know, like one of my friends is going through a divorce right now, and she was telling me how she's like having a hard time working with her clients who are going through divorces. Like, it's really triggering a lot of stuff for her, and she's aware of it. So one of my friends who's a counselor just lost her 5-year-old daughter, and isn't heartbreaking. And we were talking about just like grief, and she's like, I just cannot work with this population right now. And then sometimes things will, you know, I had another friend who, when she does sexual trauma work, and when she had her own children, she found herself getting re-triggered from her own childhood. And she had to take a break from doing that work and sort that out for a bit. So I think it's such a great question, and it's just perpetually staying aware and connected. And when you need to, going into counseling, and sometimes you might only need a couple of sessions to kind of make sense of what's going on for you.
Yeah, I always find that kind of question interesting, because when you ask the amount of people who are in a counseling program, have you had therapy? I'm always surprised the amount that say no. And I'm like, would you like to be in a plane with someone who says, I'm going to be a pilot, and your response is, have you been in a plane before? And they go, no, but I definitely want you to get in my plane, and I'm going to fly you around. I wouldn't get in that plane. You want to be a pilot, but you've never been flying. That scares me a little, right? And then at the same part of that, thinking about how many times developmentally, when you grow, your stuff grows. You change, your stuff changes, and throughout the life. So we're really kind of coming to, we're really past our time. So I'm going to wrap us up.
I could just say, we actually kind of wrapped up the presentation at a pretty good place, because what was left was activities. Like, I had so I love creative and expressive arts activities. I know Dr. Stewart Spencer does too. She uses a lot of metaphor and things like that. To me, there's nothing as powerful. Talking at our clients or listening to them talk at us is not, it's not productive. So I challenge everyone to go deeper and experience. And you experience through activities and engagement, and asking clients to be in a way with their thinking and problems that they've never, and solutions, that they've never been before. So that's what I have left on that PowerPoint, is all activities. And again, every one of those activities you could use with any population. So I think that you guys all have access to that. And if you don't, you can just shoot me an email and I'll send you that. And if you're interested in any of those articles as well, I'm happy to send those on. Could I just send those to you? And then
just send it to me.
I'll just kind of pick a hodgepodge of articles that I think are clinically interesting. And then we can share those with you. Thank you, guys.
All right. Well, thank you everyone for joining us. Like I said, we're working on getting the recordings out so you can kind of go back and breeze through any of them whenever you want to hear it and kind of cipher back through it. I want to thank Dr. Kress so much for coming. Love to hear her talk. I think we could sit here and literally go on and on, because this is this is exactly what happens when we get in the same space. But otherwise, thank you all. Appreciate it. And see you guys in class.
Thanks, guys. Bye.
Bye.